So good morning. We are going to start our sessions. Thank you for the Minister of Health for his opening ceremony. Good morning. We would like to begin the directing those who have registered for the workshop to please proceed upstairs to your designated workshop area. We are honored to have with us today Dr. Daniel Holmes earned his undergraduate degree in chemical physics from the University of Toronto. He went to medical school at the University of British Columbia, where he also did his residency in medical biochemistry. He's a clinical professor of pathology and laboratory medicine at UBC and head and medical director of the Department of Pathology and Laboratory Medicine at St. Paul Hospitals in Vancouver, and intern medical director of British Columbia Professional Toxicology Laboratory. Interests include clinical endocrinology with a focus in secondary hypertension, lipidology, clinical mass spectrometry, and data science and application to data automations, visualizations, and the clinical utilization. Dr. Dan, can you start our lecture, please?
Thank you very much for that kind introduction, Ahmad. Ahmad and I have known each other for a long time because he trained in Vancouver also, and so we had opportunity to spend 5 years together there in British Columbia. When I was approached by Maisa and Ahmad to speak on a topic that wasn't really scientific, I was like, oh no, I'm talking about leadership in lab medicine. And for me, it's kind of a more difficult thing to talk about because there's no numbers, there's no chemistry, and so it's not scientifically grounded, but I hope it will be impactful all the same. I'm going to tell you what I've learned about leadership in the last 10 years. I have a couple of conflicts of interest. I sit on the board of directors of MSACL, which is a clinical mass spectrometry meeting going on next week in the United States, and I sit on the board of directors of the American Association for Clinical Chemistry, which has now been rebranded to the Association for Diagnostics and Laboratory Medicine, and I've received honoraria and from Roche Diagnostics also. So this is my leadership journey. I qualified in medical biochemistry in Canada in 2006, and I assumed leadership over the clinical chemistry division of Providence Health in Vancouver in 2008. And for the first 10 years of my time in lab medicine, I put my head down and my job was to get things done. What I wanted to do was protect our lab from becoming outdated. So the first thing I did was get a mass spectrometer in, and in the ensuing 8 years, we put out 25 lab-developed tests. So I built up the largest portfolio of lab-developed tests in Western Canada in a hospital lab, and many of them were quite complex. And incidentally, if anybody is interested in our methodologies, I freely share our methodologies and sample preps with anybody who wants them. So I focused on the work. I focused on being excellent at the work, and I didn't develop any of these soft skills that have to do with leadership, at least not in any way that I recognized was happening. Maybe it was happening, but it was happening organically, not because I tried. I focused all of my attention on being a good medical biochemist and setting up a lab-developed testing mass spectrometry lab. In 2014, I applied to be the head of the Department of Pathology and Lab Medicine, but a more senior individual had applied also, and I'm glad. I'm glad that I did not get that position at that time because I wasn't ready. And when I went under Dr. Martin Trotter for the next 5 years, I learned a lot of things that I had never learned before just by watching him. And so I was appreciative, although at first it was a blow to my ego. That was the learning, that was the blow to my ego. Because when you want to be a good leader, ego has to take a back seat a lot of the time. And so in 2020, I assumed the leadership of the Department of Laboratory Medicine in Providence Health, but I want you to note the date, April the 1st, 2020, 2 weeks into the pandemic. And it was a very difficult time to be in leadership. So I call this my baptism of fire. It was a very difficult time. So I had a number of very large issues to deal with that affected the whole province of British Columbia, which incidentally is about the size of Kuwait in terms of its population. We had the provincial pandemic response. There were very tense meetings across the province of British Columbia related to swab availability and reagent availability and testing capacity. I think probably you were also affected by the fact that Roche Diagnostics could not manufacture its reagent fast enough for the Cobas 6800 and 8800 instruments, and so there was a squabble, that is a conflict over who would get the reagent and who would be providing the testing. And so what I had to do was jump into lab-developed testing in genomics also. So we moved everything off the Cobas 6800 that we could and moved it onto lab-developed testing also on Cobas platforms, but the less automated Cobas platforms. The other challenging thing for me is that the pandemic response had a very political nature to it, and the people who put in charge of it in laboratory were not subject matter experts. They happened to be anatomical pathologists, which meant that they could not make decisions based on their prior experience. They had to make decisions based on sort of a collaborative model, and sometimes they weren't able to fully understand the ramifications, so that was a challenge, communicating with them and working with them. And then there was a protracted unaddressed quality issue that there was an HR issue that I had to deal with at my institution, and there was all sorts of interdepartmental conflict related to the pandemic response, really. And so I was thrust into all of these very difficult situations, and through those situations I had to navigate cooperatively to come to solutions. And I want to talk to you about the kinds of things I learned along the way so that there's actually something that you can hang on to out of this discussion and this talk. There are a number of, leadership it has structure, not the same way we have structure in biochemistry where we have well-defined topics and things like that, but leadership has a kind of scientific backing to it, and people analyze leadership and talk about the different kinds of leadership that there is. And there's sort of 6 to 10 leadership styles defined, and what you need to do as you enter a leadership position, which I would encourage you to do, once you get good at what you're doing, you should try to enter a leadership position. You need to figure out which kind of leadership style is you. Now, you're not going to fall into one category completely, just like no personality falls perfectly into a category. You're going to have components from different leadership styles, but you have to figure out what your dominant leadership style is and make good use of it. There's no right answer on what leadership style you should have. They have pluses and minuses, just like a personality has pluses and minuses. And you have to leverage the positives and minimize the negatives. So a transformational leader is somebody who takes on the leadership role and says, we're going to go to where no man has gone before. We're gonna do something new, and the focus is on changing the environment and refreshing the environment and forging new territory. And so the focus is always on the future and rallying people on this future vision. That's kind of an inspirational leader. It's people make a business out of this, teaching you how to be this way, like Tony Robbins and other people like that. They want you to be like larger than life. That's not me, but it is a style of leadership. Another form of leadership is actually an area of weakness for me, and I'll explain to you why, is delegative leadership. This is somebody who's really good at telling other people what to do, not in a bossy way, but picking the right person to do the task. The nice thing about being delegative is that you can get a lot of things done. The bad thing about being delegative is that you might not be doing those things yourself, and that can be viewed negatively. But it's a very important skill to be able to appropriately delegate tasks to other people, even if you think that you can do those tasks better. And that's the challenge of being good at what you do, is that as you get really good, you say, you say to yourself, well, I'm going to do that, and I'm going to do this, and I'm going to do that, and you spread yourself too thin, and you get less done, because there's only one of you. Authoritative leadership is the leader that nobody particularly likes, but can be useful in certain situations. An authoritative leader is somebody who's bossy. But there's a good way to be bossy. There's a way to be bossy that isn't nasty and mean. There's a way to be, confident and leading the charge and taking people places where they need to go and dealing with the, bad behavior in a confident and powerful way, without being a micromanager. But the risk of the authoritative leader is that they are in the weeds on everything and controlling every aspect of things. That's not me either. A transactional leader is somebody who focuses on making things happen in a tit-for-tat fashion. That is, everything is a transaction. You are going to do this for me, and I'm going to do this for you. You're going to take on this job, and I'm going to give you this benefit or bonus or this leadership activity in exchange for what you do. So it focuses on like an economy of trades. It is a way of getting things done. It can work. It's not my style. Democratic leadership. So the democratic leader says to everybody in the group, where are we headed? Where are we going to go? And people put forth ideas, and you put them up on the screen, and then you vote on them, and the decisions are made in a democratic fashion. And the role of the leader is to enforce the outcome of the democratic process, to make sure that what actually was voted on becomes what we actually do. And that has good aspects and bad aspects. It's nice everybody gets representative and nobody can say that things are unfair, but the bad aspect of it is that sometimes the group of people don't really actually know what they need to do to get where they want to go, and they can make bad decisions. Simple example, in our radiology department, some of the radiologists were asking to work from home. And the leader said, okay, well, we can vote on it and we can make the decision to work from home, but here's the challenge. If you start working from home, the value proposition of you being a radiologist at this hospital will start to disappear, and the clinicians will not know who you are, and they will not have a relationship with you. And the downside of that is that you will become abstracted from the very care you're trying to deliver, and somebody else in another jurisdiction could make an end run for your work. So he says, if we make that decision, that's going to be bad for us in the long term, might be good for you in the short term. So that's an example where you could approach that process democratically, but the outcome might be very deleterious. As it turned out, in one health authority, they voted and they started work from home. In the other health authority, the leader said, no, we're not going to work from home because it's going to put our jobs at risk. Finally, this is what I'm aspiring to be. I'm aspiring to be a servant leader. What is a servant leader? So I'm going to talk about my aspired leadership style. I don't say that I'm an achiever of this leadership style because I think that would be arrogant. But here's my preferred leadership style. I like to work the hardest of everybody so that nobody can say I'm not pulling my weight. I want to be the person that is identified as the hardest worker. There are very simple things you can do to make other people feel like you are placing them before yourself. You can learn their names. It's a very simple thing to do. When you go into the lab, no matter how lowly a position a person has, knowing their name and addressing them by name makes them feel valued and important. You should always advocate for the needs of other people, not for your own needs. Advocate for the needs of your workers. Advocate for the needs of the techs. Advocate for the needs of the lab assistants, the other physicians, and the scientists. Whenever you're in a situation where there is praise being given, and it happens to fall on you, take the opportunity, if it is granted you, to identify the people that made it possible that aren't you. Make sure that you give people credit for things that they have done contributing to your work. Have integrity. Be known for always telling the truth, but doing it with gentleness and respect. That was something I needed to learn. I used to value the raw truth as the most important thing, but actually telling the truth alone isn't good enough. You have to tell it with gentleness and respect. When there's a benefit to be had through some process, give those benefits to other people, because this demonstrates your faith in God. When you give something valuable to somebody else that could create a risk for you in the future, you are demonstrating faith that God is going to make it up for you. So always give benefits to other people. There's a concept of meekness. Meekness is the restraint of power. Meekness isn't weakness. Meekness is when you have the power to do something, but you restrain that power in order to do good. Like Superman is meek, right? He has the power to do many things, but he restrains the power except for situations where he absolutely needs it. Humility, be willing to work below your pay grade, and forgiveness, very important. Don't hold grudges against people. Those are the features of servant leadership. But I would be remiss in not talking to you about my mistakes. So I'm going to talk to you about the mistakes I made. If anyone likes to play chess, hopefully you can see the mistake that the white has tried to get that rook there, but has missed the fact that there's checkmate in front of the white king. So here are some of my mistakes. Google Translate did this translation, so I trust that it's okay, because I can't translate it. But it says, a fool gives full vent to his anger. So one of the things that I had not learned by working in my cloistered environment for 10 years, setting up lab-developed tests, is when something made me mad, I let myself get mad. You're going to be upset, because when you assume a leadership role, there are going to be people elsewhere in other hospitals, in other jurisdictions, or even in your own lab who are going to deliberately test your leadership. They're going to deliberately try to annoy you to see if they can in English we say, get your goat. So if they can upset you. As I said before, you're going to be upset, and when you speak the truth, it is important to remember how to speak the truth as much as speaking the truth. Because when the truth is imprudently delivered, it will not be regarded as true. So whatever you need to say, you have to say it politely and respectfully, even if you have not been treated politely or respectfully. You have to calmly state the truth over and over again. Somebody might not be telling the truth, and you can't get upset about this. You can't lose your temper when somebody's not telling the truth. You need to just calmly stick to the truth, say it gently and respectfully. Show respect to those who you do not feel deserve respect. This is a manner of self-control that does not go unnoticed. If somebody is treating you poorly and you treat them with respect, everybody notices the self-restraint. Now, empathy, this is the key idea, because when somebody is treating you poorly and you show them respect, you're showing empathy to somebody who's totally undeserving of empathy. That's a divine quality, because if you can show kindness to somebody who's being rude, that's a divine quality. Only God can do that and teach you to do that. And forgive wrongdoing even when the other party is not sorry, because it's better for you. Because when you don't forgive somebody for doing something wrong, you're the only one who suffers. Because if I'm in my head, I'm like, I can't stand that guy. He drives me crazy. The only person suffering is me. Do you think when I think something negative about something else, they go, oh, that hurts? No, they don't. Only I suffer when I don't forgive. So there's great power in forgiveness. When you're upset, don't write an email. Don't write that email. Don't click send. Maybe write it and save it in drafts. Look at it tomorrow. Look at it in 2 days. Take your time. Arrange face-to-face meetings where you can just later, a few days from now, calmly discuss. So I have a lot of Iranian trainees and Iranian colleagues, because Canada has a lot, Vancouver particularly has a lot of Iranians. So I discovered that the word for squirrel is the same in Arabic as Farsi. It's sanjab in Farsi. I understand it's sanujab in Arabic. Anyways, so I have this concept with my friends, my Iranian friends. It's called sanjab and gerdu. Gerdu is walnut, but I guess in Arabic that is juz. Is that? Yeah. So I have my concept of sanjab and gerdu, squirrels and walnuts. And I always say to my friend Maziar, don't get upset. This is squirrels and walnuts. He says, what do you mean? I said, I mean this. Everything that we are fighting about, everything that people are having conflict about, everything that people are jostling about for, are just just walnuts. We are squirrels, and this is walnuts. Squirrels in the park, they fight over walnuts. I said, when we get old, when we look at this at the end of our lives, this is nothing. So just remember, we are sanjab, and we're fighting over walnuts. We need to be calm and remember that these things that we're squabbling over are not important. A little story. And this story is meant to illustrate that one of the things I learned in leadership was that you must make friends. If you do not know people, you are just an idea in their head. You're just an email, signature. They don't know you. So, I'll tell you this story, and you can go look it up. It relates to looking after poor people, but it has an application here. There was a man who was a manager in a company, a senior manager in a company, and he found out that his boss thought that he was no good and that his boss was going to fire him. So knowing that his boss was going to fire him in 2 weeks, he said, I'm going to make soft landing for myself. This is how I'm going to do it. When people came to pay their bills, he'd say, how much do you owe? They'd say, well, I owe 1,000. He said, well, make it 500. And the person only pays 500. Another person comes and he says, how much do you owe? He says, I owe 3,000. He says, make it 1,500. And so to each person who came to pay bills in the coming weeks, he would knock money off the bill, and he would make for himself all of these friends so that when he finally got fired, he could say, hey, remember me? I'm the guy who lowered your bill. That principle of having, now that's illegal. I'm not suggesting that you steal from the company. What I'm suggesting is that this person was forward thinking about his future. When this story is told, the idea is actually that when you give money to poor people, that you are buying for yourself friends in heaven, right? That the poor will be there in heaven, they will be able to advocate for you. But this applies in lab medicine also, believe it or not, that if I do a good turn to other people and form relationships with other people, then when it comes time for something to happen in lab, you're not just an idea. So you have to get out of your office. I know that people in pathology and lab medicine tend to hide in their offices. I'm one of them. You need to get out of your office and make relationships with people. The other thing that's been a frustration for me is that sometimes, particularly in public sector, there's people who are not all that good at their job, and you're not going to get them out of their job. They're going to be in that job because that's the nature of public sector. Maybe they've been over-promoted, maybe they don't work as hard as you would like, maybe they're not all that skilled. I used to get really frustrated by this. I no longer get frustrated by this. I just say to myself, my job is to help this person, whatever their motives, be the best that they can be within the confines of their ability. So I just work with their limitations, and I try to get achieved what we're going to achieve, what I want to see achieved, yes, on a longer timeline, but I have to work with these people, and when I work with them, I can have influence over them. If I get frustrated, that's not going to help. Face-to-face in a Zoom world. The world has become very Zoomy, as you know, and it has placed convenience over relationship. Relationships cost time and they cost convenience, but there's many intangible benefits. Less is accomplished in the short term when you have face-to-face meetings. More is accomplished in the long term. So when you formulate those relationships, when you foster relationships, you can get things done in the long term. Don't just focus on getting things done quickly. This is a marathon. Maybe it's an ultra marathon, certainly not a sprint. So face-to-face meetings build loyalty, and they build friendship, and they build hardworking colleagues. Take the time to make small gestures of kindness along the way. Take people to lunch, provide coffee and snacks, celebrate achievements, send around an email when someone receives an award, make sure they are recognized. And finally, the last section, as a leader, you must have vision. Solomon said, without a vision, a people perishes. This is very important. The thing about chemistry, more than anatomical pathology or microbiology, is you can coast in clinical chemistry. Don't coast. When you coast in clinical chemistry, this is like driving a car and never changing its oil and spark plugs, never taking it for service. You can let it run a long time, but eventually it is going to break down. You don't want that to happen to you. You want to be diligently taking care of the vehicle. And so you must be always thinking about the future. Be an early adopter, be curious, collaborate, and share. So, I want to talk to you about some objective things that I view as the important things for the future of our lab. Back to technologies. So, for microbiology, the future is going to be total lab automation. And so you have to have your eye on the totally automated regular microbiology lab, and then the other future that goes with that is the genomics, the metagenomic sequencing kind of thing, which I'm sure will come up. But we have just installed a WASP lab, and so we have the automated plating system, and then with our new hospital build, which is coming up in 2027, we will have total lab automation. Genomics is the future of microbiology as far as I can tell, and in fact, it may take over some of the traditional culture techniques, because if you can do this so-called metagenomic sequencing where you amplify everything, you can quantitatively specify which organisms, viral, bacterial, or whatever, are in your specimen. What we are doing right now with virology is we are doing cloud pipelines, which I'll discuss tomorrow, for CMV and for HPV. So we have a fully automated pipeline from the Oxford Nanopore GridION up to Microsoft Azure Cloud processing of the genomes and then reports coming back down. That was not a small task, and I didn't have much role in it except to support it. For anatomical pathology, the future is digital pathology, and so this is scanned slides like radiology has. So we've been working pretty hard for a year to do groundwork for a digital pathology program provincially. And finally, for clinical chemistry, pre and post analytical automation is the big thing, like being able to do all of your sample centrifugation and aliquoting up on the front end, optimizing those processes to make your system more scalable. And they're available in every one of the major vendors. We happen to be using Roche. And then I just was able to go to Germany and see Roche Diagnostics' fully automated mass spectrometer. If you can avail yourself of that opportunity, I would do that. It's an amazing technology. They've made everything based on immunopurification. And so it's going to revolutionize how mass spectrometry service is delivered. So those are my medical visions for what is coming. And that is part of the leadership in lab medicine, to keep your eye on the technologies that are going to impact care and on the trends in laboratory diagnostics. And I hope that I've been able to convey some of the learnings that I've had through my leadership journey. I'm very thankful for the opportunity to speak to you, and I'm happy to entertain any questions at the appropriate time. I don't know if that's now or later, but thank you for your time.
Thank you, Dr. Dan. Following Dr. Dan, we have the pleasure of introducing Dr. Devaki Nair. Dr. Devaki Nair is a professor in CVD prevention and healthy inequality, University College London, Royal Free London and Health Service Laboratories in London. Professor Devi Nair is qualified from Madras Medical College of India and completed her postgraduate studies at the Royal Free Hospital, London. Her special interests include familial hyperlipidemia or hyperlipidemia of genetic origin. As an academic with University College of London, her research interest includes lipids, CVD prevention, and renal disease. She is the specialty lead for the Health Service Laboratory that serves 4 major hospitals in Northwest London. Dr. Devika.
I'd like to extend my extreme gratitude to Dr. Ahmad and team for inviting me to the Lab 24. I remember I was here probably less than 10 years ago doing the same, and I thoroughly enjoyed interacting with your trainees and with the colleagues, and thank you again for inviting me here. As a lead for a laboratory, which is a public-private partnership, there is always a conflict that inappropriate tests are being ordered by the trust which has bought the services from the private sector. And we always looking at ways of reducing inappropriate tests. And I have to say, if you put 100% of your time into the reducing inappropriate tests, and I have to confess that we are only successful with 10 to 20% of the time. So it's a really hard task. So what I'm going to go through is reasons for inappropriate utilization of the laboratory tests, the medical and the financial consequences of inappropriate utilization of the laboratory tests. So we all agree that all diagnostic tests should be supported by evidence, not duplicative of other tests or procedures already received, free from harm, truly necessary, and consistent with patients' values. So we only should request diagnostic tests which fall into these. And if you look at the tests, in chemistry or any of the pathology disciplines, a good test provides information that is useful for managing your patient and taking decisions. So, for example, if you're screening, your test should be highly sensitive and have a good negative predictive value for to be used in screening. And diagnosis, you have to have a high specificity and a positive predictive value. A bad test uses resources but fails to provide the information that you're seeking for managing your patients. An ugly test uses resources, provides information that is misleading and irrelevant, and you spend more money to sort that patient's problem. So you can actually say good, bad, and ugly and avoid the bad and ugly. So if you look at the diagnostic testing field, diagnostic testing has increased greatly. When I trained, it was a handful of tests. 30 years ago, I could request, and tests were not available, guidelines were not available, pathways were not available. But now, advances in technology, there are newer tests, no defined pathways. So you have pathways for each disease where it says these are the tests which you have to do for many of the medical conditions. It can be tumor-specific, response-specific with treatment, patient-specific, and you're looking at molecular analysis, again related to response and patient-specific, and data to help optimum therapies and individual response. So all this has increased the number of tests that we are requesting. Again, I will have to say that in the recent times, medical training is slightly different from the times before, because lots of developments, and if I ask my young daughter and son who are doctors, say, you didn't have to learn all this. Our syllabus is so big, we have very little time, and so we are overburdening the medical students. And I do feel that the clinical history taking and the physical examination skills become a little less important than the times before. And for compensating that, we request more blood tests or laboratory tests. Now, laboratories also use, the clinicians are also using laboratory tests to look at failures with an aim to reduce hospital readmissions. So all these are the reasons for the increase in the workload in diagnostic field. So what is inappropriate testing? An inappropriate test is ordered, so you order something which is not right. For example, if a patient gets admitted for pancreatitis, you still order amylase instead of a lipase, so inappropriate test is ordered. Then it complicates with the diagnosis. It maybe has a salivary component to it, so it's an inappropriate test that is ordered. An appropriate test is not ordered. In the first instance, you're not ordering an appropriate test. It results in inappropriate tests and then a circle of event which leads to more and more investigations. Or an appropriate test is misapplied, so misapplied or misinterpreted. Or an appropriate test is ordered, but a delay in the total testing process. So the sample is sent, and the laboratory either not received the sample or they received the sample for some reasons. It's not turned around in the right time, and so more tests are requested, and again, that can lead to inappropriate testing or duplication. And we can do an appropriate test, and we can, the result may be inaccurate. So these are the ways of inappropriate testing. The total testing process, it's like brain to brain. You can see the patient's brain. The physician thinks about the test, orders the test. There is a collection. There is identification of the sample, transportation of the sample, preparation of the sample, analysis, reporting, and the laboratory physician interpreting, helping to interpret, and then it goes back to the physicians. And there are several notes where these inappropriateness can occur and leading to inappropriate testing. So Australia has really a big drive to reduce the test and the thing, and it's choosing widely. And this is a survey done by the Australian Choosing Widely program. And if you look at the GP, if they asked quite a few GPs in primary care for what are the reasons for primary unnecessary tests, and the top one was patient's expectation. And as you can see, Google, internet teaches them a lot, more than more than what they believe in the doctors, and therefore they come up. And patient's expectation could be one of the reasons. Potential medical litigation. These days, medical litigation is another problem. So it's doctors think, oh, we will request this test. We don't want to be held responsible for not requesting and getting into trouble. Uncertainty regarding diagnosis, either due to training or difficulties with the presentation, difficulties in accessing information from doctors if the clinical details are not filled properly, if the clinician who is looking after the patient does not understand the information required, that may lead to inappropriate testing. Patient referred specifically for test or treatment procedure. You refer the patients to a specialist, and the specialist may have a battery of tests. They do it on a regular basis. It may already been done and they repeat it again. So that may be another reason. The need to keep the patients engaged is another reason they found. And taking the approach that it's better to test than not to test. So let's do everything. Junior doctors do this all the time, because before the ward rounds, the house officer would request a lot more tests than necessary, because then when the consultant comes on the ward rounds, they can say, oh, I have this, rather than the consultant asking them, oh, why didn't you do this test or that test? And the recommended tests, the treatment or procedures available, and or other reasons which they haven't given a reason for it. The specialists, again, specialists also over-request, and difficulties in accessing information from doctors in other settings. So when referred, they don't have the information that they require, so they may repeat the test, which is unnecessary. Uncertainty regarding the diagnosis, because again, difficult cases. Patient's expectation again comes. Potential for medical litigation is again comes as a reason for the specialist to. Patient referred specifically for test, treatment, and procedures. Again, very similar to the primary care, not very different from the primary care. And if you did a survey for the GPs and the specialists, and say the GPs and the specialists always cite patient expectation as the major driver. The patients, only 16% of the surveyed in Australia said that they asked for the test. So there is a disparity in what each one of us believe. So what are the factors that determine inappropriate requesting from a laboratory? So we're all very good in organizing test panels rather than a la carte, because I call it as a supermarket trolley culture. You know, you go to the supermarket, you see lots of things, and you put everything into the trolley, and that's what, the test repertoire comes, and you tick all the boxes. And I also call it a tick box syndrome. The junior doctor ticks all the tests and then sends one sample, because we can process samples quite quickly and we can process around 600 analytes within an hour or so. So the test becomes easier, and so they request without looking into that. And we're also at fault in the laboratory. We help them to create the panels. We create profiles, making it easier for them. And once we create an initial profile, they may not realize this is for the initial consultation. They may use the same profile repeatedly during monitoring as well. So we also have a big role in changing that culture. So the groups, profile, care sets, etc. Repetitive disorder, as I said, the same profile used every day doing the same test, because that is a hepatologic profile, that is a renal transplant profile, and every day all the tests are requested. Incomplete understanding of how to use this test, the low pre-test probability. Pre-test probability is very important, and probably the clinicians don't understand some of these aspects, and where again we in the laboratory have a role to teach them. poor understanding of the consequences of overutilization of the test. They don't understand what can go wrong. Patient pressure, yes, and defensive testing, and perverse financial incentive. And this happens in UK. I don't know whether it happens in UK. You know, if you, by February, we get a lot of lipid profile requested because they're asked, the general practitioners are asked whether they have any patients who have not been treated to guidelines for cardiovascular prevention. And you'll see, and they get incentive for that. And so by February, March, all these lipid profiles will be done, whether they have a previous profile or not, they will be done, and that is another reason. And if you, you know, I remember the technique on SMAC. That is the first time the sequential multiple analyzer with the computer with the profile started. And from that time onwards, the progress is into making the tests available, multiple analyzers being available. So lab-related factors. We also may be contributing to the inappropriate testing by processes within the lab, which sometimes fails because we get around 3,000 to 5,000 samples a day in a big laboratory, and that also can result in some of our problems. Time of collection relative to the time of management decision, the workload is high, and we can't provide the result in time, and therefore the doctor requests the tests again. Relative to therapy, drug levels relative to the dose, you're looking for the peak level for the drug, the trough level, and they don't do the right ones, and relative to the time of the day, they don't do the right one, and they have to repeat the test. So these things can happen, and which we may be able to have a control over the physicians by appropriately educating and instructing them. Proper collection techniques. Sometimes proper collection techniques fail, and therefore resulting in appropriate testing and resulting in a series of other investigations being carried out. Labeling is a problem, and the laboratory needs to have a policy for unlabeled and mislabeled samples. And again, this can also improve with laboratory professionals working with the clinician team, and therefore reducing the inappropriate testing due to that. Storage and transport can also be a problem. Protection, some tests require protection from light. Transport to the lab may have conditions. Blood gas samples which are not collected appropriately. Serum chemistry is not appropriately collected. The pneumatic tube considerations, if they do not realize what can be sent through the pneumatic tube, and this thing, and inappropriate testing and repeat testing can be a problem. So there may be issues within the lab as well. So the pretest probability is an important consideration. It's critically important to test ordering, and if the disorder has a low pretest probability, then even a very sensitive and specific test may have little clinical utility. And if the pretest probability is very high, tests may not provide much additional certainty for diagnosis. And let me go through. When a pretest probability is in the range between 30 and 70%, at a pretest probability of 50%, I'm sure many of you know about the pretest probability and how to look for that. A test that is 95% sensitive and specific yields a positive predictive value of 95% and a negative predictive value of 95%. And again, this is important to consider the pretest probability when requesting test, and educating the doctors who request the test about the pretest probability is important, and it's a role which we in biochemistry can do. And how does the patient's diagnosis impact on the test? How does the patient's treatment impact on the test? There may be other things which can affect galactose and maltose containing medication, and the POCT glucose testing interference, D-dimer in a surgical patients, HbA1 and a shortened lifespan. These are all examples, and they get the wrong results, and repeatedly they say, I don't believe that, and this thing, and they keep requesting. So what are the problems with over-testing? The patient issues, pain and morbidity from repeated venipunctures. Nobody likes repeated venipunctures. And I can tell you in the inpatients, every day people take Usinase, liver and renal in our hospital. And we tried to make Tuesday a non-bleeding day, whereby we reduced some of the tests. So it may not be, we said on Tuesday we will only do tests that are necessary. So the junior doctors don't do every day the Usinase, LFTs and other tests on a routine. Follow-up of clinically irrelevant abnormal results. The more tests you request, it will turn up irrelevant tests, and you may have to follow up that. You may be just tracking the numbers instead of the clinical picture and instituting inappropriate therapies because you're following the numbers. Economic and environmental issues, lack of reimbursement. In some countries, the reimbursement will depend on disease specific, and the reimbursement may not happen into the lab for inpatient testing. And you're also generating biohazardous waste by doing more and more because you have to dispose, and there is a cost for disposing all these biological samples, biohazard samples. So all these are the problems. And one interesting aspect is how much of iatrogenic anemia we cause by taking blood samples. It's so easy to send a sample to the laboratory every day and get the results within minutes. In the general wards, if you do the average, this is from a study published in New England Journal of Medicine, and another one in chest. And if you look at the general ward, 1.1 drop per day. On an average, you take around 12.4 ml of blood, and in a hospital admission of up to 10 to 20 days, you could take up to 175 ml during hospitalization. In ICU, it's again 3.4 draws, and average is 45 ml, and the total is 762 ml in that study. And if they had an arterial line, it's around 4 draws because it's easier to take blood, and they took around 944 during the hospitalization. And the presence of arterial line in ICU patients increased the blood volume loss from phlebotomy by 44%. Critically ill patients may not have the bone marrow reserve and the erythropoietin drive to compensate for this iatrogenic anemia, and then you may have to give transfusion. Other risks may be nerve damage, arterial damage, venous sclerosis, and infection. So there are bad things that can happen with repeated blood testing, and especially inappropriate blood testing. Then this is very relevant to biochemistry. Abnormal tests that are irrelevant. So all quantitative laboratory tests, normal or the reference range, are based on the mean plus or minus 2 ST. That's how we report. So you would expect 5% of the normal patients will have values outside this range we quote. If a patient has 10 tests ordered, each with a 5% chance of the test may have a result outside the normal range, then there is a 50% chance that at least one test will have an abnormal result. This is especially true when ordering chemistry panels and profiles. So you may have to sort out these irrelevant tests or irrelevant tests for that condition. So if the patient has come for I still remember a full profile being asked from accident emergency with a toe fracture. The patient has come with a toe fracture, and they ticked all the boxes, and they had to deal with an abnormal thyroid function in the thing, which would have been done by the general practitioner. So those are the things. And what can we do to reduce the inappropriate lab utilization? It has to be clinician-led. This is from my experience because they appointed 2 managers, not clinical, to organize the reduction in testing because we wanted to save money, and they wanted to save £1 million in from pathology budget by reducing the number of tests, and they employed 2 managers who had no clinical experience, and we failed drastically. And I don't think anything has happened in the last 8 months because the clinician engagement has not been as good as if the clinician engaged. 4 years ago, it was clinically led, and all the clinical pathology leads were involved in this initiative, and we were able to reduce by 20% of the inappropriate testing, thereby showing that we could. Because the hospital was not able to provide funding for the clinical team, they thought they would engage the managers, and it was completely wasted. Another way the resources waste. And we should emphasize on the quality of care and harm prevention. It should be consumer or the patient focused. It should be evidence-based, multi-professional, and it should be transparent. And we should all be very transparent about our aim with the clinicians. We should start baby steps with the start a conversation, effect a culture shift, and clinical biochemists have a large role in talking to the clinician, initializing. And if you look at the Choosing Widely project, 20 countries are part of that, and it's a growing participation of that project. And, as I heard from the previous talk from Their Excellency, I see that the laboratories are all connected, and therefore it's even more easier for you because we are all fragmented. Each lab is different. Some labs are united, some labs are here. Because everyone is together, it must be very easy for you to start projects on reducing testing. This is a meta-analysis of 15 years of inappropriate laboratory testing. 2/3 of the laboratory investigations ordered during hospitalization did not influence management decisions. Factors independently associated with overuse of diagnosis included longer stay. So if you use more tests, the hospital stay is also increased, which increases the cost. And again, an unfavorable outcome, age, etc., inability to establish diagnosis may be the reason, but it increases the hospitalization. Redundant ordering of tests. Some tests have become redundant. For example, CKMB, we don't use it for diagnosis of MI. Myoglobin, we don't use it for diagnosis of MI. And if you don't remove that from our profile, to remove from the test repertoire, some people who believe that they are useful are likely. So the redundant tests must be removed immediately when new guidelines come. So when they looked at that, the arterial blood gas was the least overused test because it's difficult to take blood sample, it's painful. So of all the tests, the ABG was the least overused. Trainees had the least awareness of the cost of the laboratory tests because we don't teach them on the budget. We don't teach them on the importance of saving money on laboratory tests and all the other associated medical complications of overuse of the tests. And intervention, including audit, education, alert for doctors were introduced. And when they introduced this, there was an immediate effect of reducing the test, but after that it was forgotten and they went back. So it should be a continuous process, and we shouldn't stop after doing all the things what we want to do. These are again from the same from similar findings. Repeat electrolyte panels indicate 10% were unnecessary, and 65% of cases a single test could have substituted for the entire panel. And the study of the impact on potassium ordering showed that if you used an algorithm that reduced the potassium tests in the blood loss and transfusion costs by 34%. So there is a lot of gain financially and medically by reducing that. What do we do? CPD activities, face-to-face educational visits, online case studies, feedback to the GPs and specialists. We can have news on the laboratory systems, videos on the laboratory system, patient action plan, toolkits, resources we could develop, and which are useful for the patient, as well as monthly webinars for the doctors. Provide information on test costs. We can reduce the amount, the tests that the staff, the house staff, the junior doctors can requests. So the most expensive tests need authorization from the consultant. So we do have some systems where the very expensive test has to be authorized by the consultant rather than the junior doctors to reduce the cost. And inappropriate testing, requisition designing, that needs to be carefully done so that the initial profile is not repeated every time, and it's done. And review of that by the laboratory physician on a regular basis is also important. Electronic patient record warnings. So we have in our system, do you want this test again? You have ordered this test 10 days ago. So you can have warnings and reminders, then people don't. So when they request a second time, that warnings, education and incentives again can help. And if you look at the Association of the Pathology, the American Pathology Association, there are tests which, which they have recommended don't use. Don't use plasma catecholamines to evaluate a patient for pheochromocytoma, saying instead use plasma-free metanephrine, so urinary fraction metanephrine. So, there are several examples there. I've just put a few. Don't use ESR. We reduced ESR, took out ESR completely from our profile because CRP is a better inflammatory marker. So there are tests which you can take out from the system so that people don't request those tests. Then preoperative testing for low-risk surgeries is another thing which you can look at. And population-based screening for 25-hydroxyvitamin D deficiency is another one they looked at. So there are several examples and so on. And as I said, redundant tests should be taken out. You can choose not to do ALT and do just AST. And then if the AST is raised, you can do ALT. There will be just tests that trip off the tongue for the juniors, calcium, magnesium, phosphorus, organize all the. So these are the things which we could take. Another one is repeat testing is another way to reduce inappropriate testing. How fast do tests change? The half-life is important. There is no use in going and doing a second test, not considering the half-life of the test. And if the WBC is normal, there is no use in doing a differential. So you can put, in the electronic patient record, comments to say that this is not necessary. The Royal College of Pathologists came up with the minimum testing interval, and there are around 200 tests which have the minimum testing interval on the system, and it's based on the test properties such as analytical characters, biomarker half-life, and the clinical context in which the test is used. And implementing the minimal testing interval in hospital reduces hospital-acquired anemia, risk of injury, and all the medical complications associated with over-testing. So oversampling artifacts, all that is reduced with MRI. So again, educational efforts. We did a little booklet for the foundation trainees regarding the MRI, and the lists are given to them, the usual testing are given to them as a little booklet, so they can use that as a guide to do that. Audit and feedback interventions, and educating the clinicians, integrating the alerts, the MRI alerts. Now we have MRI alerts within the system. So if vitamin D has been requested repeatedly, we'll say there is no need for resisting, and we cancel the request. And we keep the sample for 15 days in case there is a reason by the clinician for re-requesting the test, but we cancel the request in the laboratory. So the laboratory has a big role in controlling these tests which are requested for Many clinicians either don't know about the minimum testing intervals or react defensively when asked to use it. So educational efforts is very important. Automating intervention is important. As I said, sorry for the repeats. And we need to consider impact on patient care decisions. Make physicians think, what will I do if the test is negative or normal or positive or abnormal? If the answer is essentially the same for both, then the test has little utility, like haptoglobin and anemia. Will the result be available before the patient is discharged? There are several times we do the test, the patient is already discharged and never looked at. Chasing the diagnostic certainty. How much information is required before treatment is initiated or withheld? And these are the things which we can get involved. How fast do I expect the test to change? What is the best monitoring test for a disorder in question? How much change would trigger a therapeutic intervention? Once an intervention is monitoring still needed? These are the questions which we need to make the clinicians think. So what are the appropriate steps for appropriate testing? Well, from interventions that improve laboratory, gentle guidance to strong restrictions. Strong restrictions can happen. Recognize individual clinicians for their contributions. Praise them for their efforts. If they're following something which you have instituted, praise them for their contribution. Inspire others to implement such programs. Demonstrate how processes are driving change in healthcare and how it's saving costs and how it's saving harm for the patient. Help clinicians learn from each other. And this also reduces laboratory errors and patient safety, save costs directly and indirectly. And what is more important, and I think in a setting in Kuwait, must be quite unique that all your laboratories connected. A laboratory manual is a very important aspect with the right information. Probably we don't pay much attention to include inappropriate testing as part of the laboratory manual, and the clinical laboratory should maintain an online laboratory manual that is constantly updated with information to reduce the inappropriate testing. It should have information about sample type, amount, minimum testing interval availability and turnaround time, patient preparation, collection instructions, sample handling, test utilizations there, and the MRI, the minimum testing interval, etc., should be part of that. Thank you.
Thank you, Dr. Devaki, for this wonderful presentation. For any question, you can scan the QR code for any question, and we're going to keep the question for later. So again, we're going to call Dr. Daniel Holmes for his next presentation. Dr. Daniel.
So I promised that Dr. Nair and I did not collude, but this is like a perfect segue, because I want to talk about all the things that we did with data mining activities to improve laboratory utilization in our healthcare system. But we had a very good opportunity because we were implementing a new electronic health record. So this was all driven by an electronic health record that was implemented over 14 hospitals, a 10-year process. So just by way of background, Dr. Nair mentioned some of these things. There's increasing sensitivity to the careless use of the lab medicine resource, driven by rising costs, insurer payments, the deleterious effects of this defensive medicine on patients, that is like drawing too much blood or doing a lab test that you should not have done and you get a positive result when not expecting, and a lot of investigation follows that is unnecessary. Lab shortages, pre and post-pandemic, particularly post-pandemic, we have had struggle with filling positions. Disproportionate rise. We saw a disproportionate rise in diagnostic testing after the pandemic on outpatients, about a 10% rise, because patients are more often being seen with telemedicine, and that leads the clinician to rely more heavily on lab testing rather than seeing the patient. And of course, choosing wisely, and then there's environmental concerns that are coming up more and more. So just by way of background, we started implementing a large electronic health record project called Clinical Systems Transformation, but functionally it was the implementation of Cerner in a health region comprised of, I guess altogether it's more than 14 hospitals, it's about 18 hospitals. And that was a 10-year, more than $1 billion project. And in Cerner, the order sets, the collection of orders for a particular condition are called order sets, but they call them power plans in Cerner. So I'll refer to them as power plans. The power plans that were designed initially for our Cerner project had been purchased by well-meaning health managers from an American company. And it seemed to me when I looked at them that these power plans were designed by probably by family doctors. There were some very erratic use of lab testing, things that didn't make any sense. And it was kind of alarming to us to see what the effect was going to be on lab utilization because of the highly repetitive and clinically appropriate orders. So we raised this concern, and we said, we don't want these order sets, and others raised the same concern. And so the lab design team for the Cerner project, or the Clinical Systems Transformation Project, gave us the opportunity to review all the power plans before they were implemented and make sure that the testing was compatible with the lab information system, compatible with the vendor choices at the various hospitals, and that we could try and curb inappropriate utilization by the way we designed both the power plans and the batteries, that is the collections of tests that we often order as a supermarket shopping cart, as Dr. Nair said. So I'm going to try to give you the practical things we did, and I'm going to show you the outcome, because we did some very practical things to try to attenuate inappropriate utilization, and I'm going to show you the effects of those things. So hopefully if you're in the same situation, you can do something. So this was our big thrust to try to affect what we knew was inappropriate. So when I reviewed the internal medicine admission power plans, I discovered that TSH was ordered on every single internal medicine admission order, whether it's for COPD exacerbation, gastroenteritis, no matter what it was, there was a TSH there. Now that is a really bad idea because TSH is always abnormal in sick people because of the sick euthyroid phenomenon. And of course, the TSHs are low on these people, and then they get investigated. They have normal free T4 and they have low TSH, or they have borderline low free T4 and low TSH. These people get investigated for panhyperpituitarism, which sickness causes, right? It's like the appropriate response to sickness is to decrease your pituitary hormone levels so that you decrease your metabolism. We also saw that AST was uniformly ordered with ALT, even though they provide the same testing information, so we tried to remove AST entirely. We saw prior to the go live, or prior on our old system, that INR was universally ordered with PTT, so we broke those apart and took away that battery. As alluded to by Dr. Nair, we wanted to get rid of ESR, so we removed ESR from every single power plan, replaced with CRP. We removed amylase from every single power plan, and we replaced with lipase. And there were some peculiar panels that existed in some hospitals. And for example, in 2 major hospitals, lipase was always ordered with liver panels, and that's not an appropriate decision either. Another principle we applied: we do not display testing in tick boxes, because these power plans come up as a form and you go through and you tick what you want. Don't display tests that are not part of the core admission purpose. For example, don't display troponin for an admission unrelated to chest pain, because you're going to order the troponin, and with a high sensitivity troponin, you're going to have people that are just a little bit outside the normal range, and then they're going to get a big investigation even though they have no chest pain. And as Dr. Nair alluded to, Bayes' theorem says that when the prevalence of the disease is low, every positive is a false positive. So if the pretest probability is 0, every positive test is a false positive. So don't offer a test when the pretest probability is 0. We tried to unclick any pre-ticked orders that we could, and we did the same thing that Dr. Nair alluded to, which is having pop-ups. Now, when should we have the pop-ups that say, you ordered this test 5 days ago, 10 days ago, 20 days ago? How far should we look forward, and how far should we look into the future, into the patient's registered future orders, to say that we should not do this test? We did not use the tool that Dr. Nair alluded to. I wasn't aware of it. We just went through and made sort of clinical decisions and also statistically based decisions to make sure that we weren't providing too many pop-ups to the clinician, and we went through all 400 test codes to do that. We did that statistically, ultimately. We wanted pop-ups to occur less than 5% of their experience on that test. Another principle we applied. We pared batteries down to the minimum number of tests that could answer the question asked. So when we had a liver panel, what we originally envisioned for the liver panel was total bili, alkaline phosphatase, ALT. That's all we wanted on our liver panel. Now, we didn't win that battle, but we got pretty close, and I'll show you the effects of that. We also wanted to resist consumer-style medical practice. We didn't want, there is now a comprehensive metabolic panel. I fought very hard against it. It has 16 components in it because people order the comprehensive metabolic panel very freely, and it did hurt test utilization, which I'll show you. We didn't want that to exist, but we didn't win that battle, unfortunately. Because the clinicians are the ones who have to deal with the extra clicks, and they don't want to click the extra times. Finally, we wanted to build a case for what's called positive patient identification. Maybe you already have it. We didn't have it. This is where you have a device where you wand the patient's armband to detect the patient's identification, to facilitate collecting the correct blood on the correct patient, and also facilitating phlebotomist dispatch. I want to tell you a very interesting tale. Just as we're doing all of this, my colleague, Dr. Janet Simons, she was the one who noted this. She noted that many patients on the internal medicine ward were getting daily blood work of a very similar type, CBC and electrolytes, with no stop date specified. Even though the system was supposed to be designed that it wouldn't go more than 3 days. We had to investigate this because we found patients who were getting the identical blood work and no one was looking at it for 2 weeks, 4 weeks, 8 weeks, 3 months. One patient we found had 250 days of consecutive blood work that really wasn't being monitored. And so through the investigation, we discovered that the unit coordinators were reordering the blood work whenever the physician didn't put a stop date because it was too much work to call the physician and ask them if they wanted to continue the blood work or not. And so we looked at this computationally to see how many such patients there were and what the effects on those patients were. So we wrote some software to find those patients in the system. And this is the perfect example to follow up on Dr. Nair's talk. What we see here is we have wonderful homeostasis of sodium and urea and potassium and creatinine. But you'll notice the one thing that goes down over time is the hemoglobin. And every once in a while, we get this effect where the patient is getting a transfusion. And so this is the phenomenon that Dr. Nair was talking about, where we're doing harm by just with the very examination of the patient's blood work. So we had to write software that would find, and I want you to understand this, what we're looking for. We want to find patients who are getting blood work consecutively daily of an identical nature more than N days in a row, and we want to pick the N. So I decided, okay, let's just look for how many patients are in the hospital who have had consecutive daily blood work more than 14 days. We'll call that 14 days a run, and so we'll look for patients with runs 14 days or more. And we can change that. We can make that 10, or we could make that 7. But what we see here is I have counted how many patients on the ward are getting blood work more than 14 days in a row that is identical in nature. And I think I have, do I have a laser pointer? I don't know whether I have a laser pointer or not. Maybe I can use the mouse if I slide over here. Over here, yeah, okay. So, on average, there are 30 patients in our hospital, St. Paul's Hospital, who are getting blood work of 14 in a run of 14 days or more on any given day. So we investigated that. About half of those collections were needless. Now you can actually see that they're needless because of what happens at Christmas. Every Christmas, these runs of daily blood work disappear because people don't want to be bothered with phone calls over Christmas, so they cancel these kinds of runs of daily blood work. So you see the Christmas effect there at 2016, 2017, 2018. On the new year, we get these replicate blood work disappearing. Now, this code was kind of hard to write, but we did write it. We wrote it in the R programming language. So first thing we did was education. We told everybody in the hospital system that this was happening, and we showed them the effects on individual patients. We discontinued the practice of the unit coordinators being able to order the blood work, to reorder the blood work, and we created an electronic health record policy where if you ordered daily blood work and didn't put a stop date, that it would be interpreted as daily times 3 days, and then you would have to reorder. So these are the effects of the implementation of the education. First, we had grand rounds on October 2018, and we got, not bad, we got a little deprecation of the inappropriate ordering from 263 tests a day down to 250, and then we implemented the guideline and got that down to 230, so that's not bad. But we wanted to, as our new electronic health record came in, we wanted to hang on to the success that we had with this. So we wanted to extend this to Cerner. Now, when we went to Cerner and said, we want to make it so daily blood work stops at 3 days, they said, oh, it's not possible. And then we asked someone else, no, not possible, not possible. Now, if it's a computer, you know it's possible. It's possible to program this, so we just didn't give up. And so eventually we found someone in Cerner, a professional who worked for Cerner, who knew how to program this, and so we were able to continue with this practice, but not only have it at our hospital, but extend it to all 14 hospitals in the local network so that we would be able to induce this benefit of getting rid of replicate daily blood work. So now we're going to do a pre and post on all of those interventions that I just described. How much of an effect did we have by breaking up the batteries, making them as small as possible, getting rid of AST, removing lipase, getting rid of TSH, for example, on the power plans. All of these effects, what were they? Actually, counting this was pretty hard. I couldn't look at all tests because when Cerner went live, the number of tests was increasing. The number of tests available was increasing, so you can't just count the raw tests, and there was lots of test codes that were just for tracking patients and things like that. They're not real. Batteries change in their size. So like, for example, in a CBC, some hospitals were using 12 components to their CBC. Some were using 16. Everybody collapses to the same number. We know that a CBC is a CBC is a CBC. There's no more work associated with those extra 4 components. So you have to be careful how you count. So for example, with CBC, we count by a prototype test, the hemoglobin. For arterial blood glasses, you're going to count with the pH only and disregard all the other tests. So this ended up being our test white list. I know this is just like a big fat list of, this is just for reference. So you can look at what we counted as a whitelisted test. These are the tests we're going to look at the effects on. And we had to correct for a lot of artifacts associated with the go live that could confuse. So we didn't want this analysis to be done by just analytics people, because they were going to make mistakes in understanding the tests, and they wouldn't know. They know so little about the lab workflows that they wouldn't know that they were making incorrect inferences. So this was very important that the clinical biochemistry people who know the workflows are working with the analytics people to make sure that the counting is correct. As it turns out, I did all of the coding here, so I knew our workflows. We don't want to count tests that have no work associated with them, like electronic EGFR rather. And I want to normalize in some way for the number of tests performed per day in a consistent manner. As it turns out, we looked at normalizing the number of tests ordered, because when you put a new electronic health record live, you might not have as many patients in the hospital at that time because things get slowed down. So you don't want to just count tests. You want to count how many tests you perform per patient. And you might want to use the inpatient census. That would be one way. As it turned out, we settled on counting the number of lab tests per day per patient that was seen by the lab, because we didn't want to count how many psychiatry patients they were. They don't affect our workload. So we limited ourselves to the number of tests per patient per day, where that denominator is the number of patients that the lab serviced. And so that was our denominator. So here's our findings overview, everything that we found through this process. Going to go through quality checks, test counts, battery design effects, the effect on emergency and ICU, the effect of the clinical collect devices, the positive patient ID, and also the effects on the replicate daily blood work. Now, I want to emphasize that decreasing replicate daily blood work has the most power, the useless test, because just decreasing an individual test doesn't mean that the collection did not occur. The biggest work and the most morbidity is the collection on the patient. If you can stop the collection at all, that's the most power. In decreasing an individual test just decreases the amount of reagent that you're using, but it doesn't necessarily have as much impact on the patient themselves. So we really were hoping for good effects on the replicate daily blood work. So we did a bunch of quality checks to make sure that we don't have any dropout, that we're not missing any specimens. So we looked at things like sodium and hemoglobin, make sure we're getting the correct number of tests per day and that they are consistent over time and that there's no data disappearing. And when we did this, we did find missing data. We filled up our database to make sure that it was correct. So here are some battery design effects. Before going live, the liver panel was ALT, AST, alkaline phosphatase, GGT, T-bil, LDH, and lipase. And you can see there's replication in AST and ALT. You can see the replication in alkaline phosphatase and GGT. You can really scratch your head about LDH, because really that's a hemolysis marker. And lipase, again, probably something that we don't need. After the go live, it was albumin, alkaline phosphatase, ALT, T-bil, and GGT. We did not think that GGT was necessary, but people in ICU wanted to use it for monitoring drug reactions. And I said, well, what do you do about those drug reactions? Well, we lower the drug. I said, so you're treating the GGT. They admitted that they're treating the GGT. The other thing is we didn't want D-bil, direct bilirubin, in there, and I'll show you that that there was direct bili was added and removed. I'll show you the effect related to that. And here we go. So this is the effect across the 9, I'm showing 9 of the 14 hospitals. This is AST, this is total test counts of AST. 2 of these hospitals did not yet go live, and so what you're seeing, I just want to make sure that we understand what we're seeing here. I'll get my mouse over here. Richmond Hospital did not go live with Cerner by the time I did this analysis. This drop you're seeing here is from the pandemic. So that's the other thing we needed to do normalization to take into account the pandemic effect, because many hospitals went live in the pandemic. So this hospital did not go live, and this hospital, UBC Hospital, did not go live. So they serve as controls. But everywhere you see a vertical dashed line, that's the go live. So let's go to our hospital, St. Paul's Hospital. We went in AST from about 150 tests per day down to about 50 tests per day. So that's a 60% reduction in the number of ASTs we do. We see a similar effect at Sechelt Hospital. We see a similar effect at Vancouver General Hospital, going from about 300 tests per day down to 100 tests per day. Lionsgate Hospital, same thing, about 60 tests per day down to about 12 tests per day. So really nice effect by removing AST from the liver panel and removing it from every power plant. Same thing with LDH. Same thing with LDH. We see really precipitous drops there in the middle in the orange at Lionsgate Hospital. We see very nice drop at our hospital, St. Paul's Hospital. And you see there's these interesting artifacts. People always come along and say, what's going on here? Well, these artifacts here, these are clinics for people with leukemia. So that's why LDH is getting ordered on those days. And you find artifacts all over when you do this kind of analysis, and then you have to go and figure out what it is, because otherwise people will challenge your analysis and say, what's this? I don't know. Well, you better find out. How do you know you're right? But eventually you figure out that you're right. You're not just seeing things. We saw a really nice effect on LDH across all the hospitals. We saw a really nice effect on lipase across the hospitals, especially the adult hospitals. See if I can get my mouse again here. Nice drop here. Not so much of a drop at our hospital because we didn't inappropriately use lipase to begin with. Lipase was not on our liver panel battery, so really nothing happened at our hospital, but Vancouver General Hospital, again, a nice drop from lipase. Direct bilirubin. So we removed direct bilirubin, and then one hospital wanted it back. They got it back, and they saw, wow, that's a big increase in direct bilirubin utilization when we add it to our liver panel, so they took it off. And you can see the effect of adding it and taking it off the battery. It's about a 5-fold effect. So again, nice drops at select hospitals that were using direct bilirubin, I would say, more enthusiastically than it needed, but not unaffected every hospital, because not every hospital had the same batteries before the go-live. So we did what is called a causal impact analysis on every test. We were able to program this and have it do it on all the tests. The causal impact analysis is a specific kind of analysis for time series to see all of the different effects that lead to statistically significant changes in the utilization. We use the R package called causal impact. I've given you the URL for that R package. And we were able to make interactive HTML for the administrators to look at to see this effect. So the point in showing this is that not all effects that we had were good. So I'm going to look at calcium as a case example. Remember I said that we created this battery called the Comprehensive Metabolic Panel that I really didn't want to have happen? The Comprehensive Metabolic Panel had calcium in it. And at our hospital, St. Paul's Hospital, this led to an increase in this is a box plot. It led, what's a violin plot technically with a box plot superimposed. It led to an increase in the calcium utilization at our hospital. And we can see that here where there's the moving average, the black line, the moving average increases. And so that was a negative effect, even though we did our best. But at other hospitals, the same set of batteries led to a decrease because prior to the go-live, they were using more calcium than we were. And so at Vancouver General Hospital, we saw a nice decrease in the calcium utilization associated with the go-live. So we did this for all tests, and overall, through all these whitelisted tests, we got about a 10% reduction in test utilization just in straight counting the numbers of testing. Now, I want to also show you effects in specific locales in the hospital, particularly emergency and ICU. These are the tests per patient per day at each of these institutions in their emergency departments only. And it may just look like a whole bunch of flat lines, but there's actually something very interesting in here to see. Let's just take our hospital as a prototype example. Before the go-live, the vertical dashed line, we have about 10 tests per patient per day, and it's about 10 tests per patient per day after the go-live. So not too much difference from that go-live. This is strictly in our emergency room. But if we go to another hospital, this hospital started out at 15 tests per patient per day, and it went down to about 12 tests per patient per day. This hospital started out at 5 tests per patient per day. It's a very small hospital, and it went up to about 8 tests per patient per day. And then there's a couple of hospitals here who have not yet gone live yet, Richmond Hospital and UBC Hospital. So they serve as controls. What's the effect? The effect is that when the hospitals go live, they all converge on about the same number of tests per patient per day. That is, you kind of get normalization of the patient care when the doctors are selecting from the same set of batteries. The small hospitals used to have very few tests per patient per day. They go up to more tests per patient per day. The big hospitals tend to use more tests per patient per day in the emerge, and they come down. And everyone's settled out around 12 tests per patient per day. That's good from a health equity standpoint because it means that patients are getting similar care in similar scenarios at different hospitals. This was generally regarded as a positive thing. Now, because I don't show you how big each of these hospitals are, you can't tell, because there's a normalization occurring here. The overall effect is a decrease when we take all the hospitals in the network, because the big hospitals saw the largest reduction in tests per patient per day, and the small hospitals had a large increase, but relative to the whole, it's small. It's only big on a percent basis. Now let's look at the ICU, which is a really interesting thing too. There are 3 ICUs in our region: Lionsgate, St. Paul's in the middle, Vancouver General on the right. We have the moving average of the 30-day moving average in black in each case. And we see that Lionsgate Hospital has 15 tests per patient per day in the ICU, pre and post go live. St. Paul's has about 15 tests per patient per day in the ICU, pre and post go live. VGH has about 25 to 30 tests per patient per day, and it settles down to about 22 tests per patient per day in their ICU. And the question is, why does this one ICU use more tests? Is it acuity? Is it batteries? Well, I looked at the tests being ordered. This is called a tree map. Turns out all the same tests are being ordered in the same proportions. So it's not the clinical practice. It's not the tests that are being ordered, the specific tests that are being ordered that is increasing utilization. It turns out that it was the frequency, that the culture of Lionsgate and St. Paul's Hospital was 3 rounds of testing per patient per day, and Vancouver General Hospital, 4 rounds of testing per patient per day. It's just a culture thing. It's a historical thing. How did I show that? I made violin plots of the distribution of the testing per patient per day. And to interpret these is quite straightforward once you know what you're looking at. The number of bulges you see represents a testing event. Okay, so, and it's proportional to the number of patients. So for example, here I'm looking at pH, and I see that I have a bulge here, 1, 2, 3, 4, 5. And the bulge is proportional to the number of people who are getting 5 tests per patient per day, 5 tests per day, or 4 tests per day, or 3 tests per day. So you can see that most patients here on the bottom right-hand pane at Vancouver General Hospital, they are getting 3 tests, 3 pHs per day. Whereas Lionsgate Hospital is averaging 2 pHs per day. And ultimately what this shows is that patients at this one hospital are having their blood work 4 times a day, most of the time, and at the other hospitals are having 3 per day. So it's just a frequency thing. And what you do with this information, you just go back and show people. And you say, okay, if you really need it, this is what's happening. But you just show them, and that can affect change. Now, I wanted to also see the effect on the replicate daily blood work. So here's another patient with a run of 87 consecutive days of blood work, and there's one spike in T-bill that you see there. So this is pre and post at this is the 2019 state. This is the pre-state before we implement all these things. And what I want you to notice is on the left at St. Paul's Hospital, we're averaging. Now I've changed the number of days in the run. I changed it to 10 from 14, so the number goes up a bit. There are 40 patients in the hospital who are getting runs of blood work of 10 days or more prior to our rules implementation. And at Vancouver General, there's 105 patients in the hospital that are getting blood work that runs 10 days or more. So that's pre-rules. Post-rules. St. Paul's has gone from 40 down to 22, so we have 50% reduction in the replicate daily blood work. VGH goes from 105 to 78, so about a 25% reduction. There was no educational process at VGH, so we're hoping that we can get that also to a 50% reduction. So we're really happy about that, and in fact, we can also tell which wards are producing the most replicate daily blood work, so we can give feedback to that hospital. So we got a 42% decrease overall in replicate daily blood work at St. Paul's, and a 26% decrease at St. Paul's Hospital. Now, just to finish up and talk about the effect of positive patient identification and how it improved turnaround time, because this was part of the whole process. So these are called PPID devices. These PPID devices happen to be called the SunQuest Clinical Collect device was the product that we were using, because the underlying lab information system is SunQuest, now rebranded to Clinisys. And we have 4 different types of priorities AM draws, stats, timed, which we use in endocrine stimulation protocols when things have to be exactly timed, or troponins exactly 2 hours after the last one. And then we have urgent. So urgent is basically the priority of emergency department. It's interesting, when you make interventions, you have to know where to look. Because if you look at the stat testing, the PPID devices had no effect on stat testing. Improvement in workflows did not affect stat testing. Stat testing was basically static. I mean, it was as good before as after. That's probably a good thing. When we looked at routine priority, regular old collections, there was no effect. Where we saw the big effect was urgent priority. So we looked at urgent priority turnaround times, and in the top pane, we have the average and the median of the order time to, the order time to the collection time, and we see a big drop in the green line of the median of about 25 minutes duration due to the positive patient identification. Why? Here's why. When we had an urgent collection prior to our go live, a piece of paper came up on a printer saying there's an urgent collection in this place. And then someone had to see the piece of paper, read the piece of paper, place the order, print the labels, put the labels in the tube system, phone the lab assistant and say, hey, you have an urgent collection on such and such a ward in such and such a room. Your stickers are coming up in the tube system. When we got the clinical collect device and there was an urgent priority collection, the lab assistant could see it immediately on the device. So that whole workflow, watching the printer, printing it out, placing the order, sending it up in the tube system with the stickers, that was eradicated. And we got a 25-minute reduction in the turnaround time of urgent collections, and it was seen in multiple hospitals. So there it is right there. There's also an improvement in the collection to receive time, although it's not as big. And so I hope what you can see from all of these things is if you want to use all the barrels in your gun. You want to use education, pop-ups, redesign of power plans or order sets, redesign of your batteries, and also improvements in workflow. When you use all of those things together, and all the replicate daily blood work blocking, when you use all of those things together, you can get some really nice effects in particular places. However, I will say, the effect that was largest was completely suppressing tests from batteries. If you can get your batteries designed to remove things that aren't necessary and people have to opt in to get them, you are far more likely to get a reduction in that particular test. So thank you very much for your time. If you have any questions, I'm happy to answer them.
Thank you, Dr. Dan. Next on our agenda, we have an exclusive industrial symposium presented by our esteemed sponsor, Sultan United Medical. Mr. Antonios Haroun, he is a professional healthcare consultant manager for Middle East and Africa with over 18 years of extensive expertise in the field of laboratory diagnostic and business management. He is responsible for the automation and diagnostic IT business development in the Middle East region. He is certified for Lean and Six Sigma and certified in change management.
Thank you for this introduction. My name is Antonio Haroun. I'm healthcare consultant manager for Middle East and Africa. And also we are responsible for the business development of automation and IT in Middle East and Africa. I'm happy to be here today with you. Thank you for giving us this opportunity to be a part of this day. And also thank you for our business partner, Inappropriate Sultan United. Today we will talk about the latest innovation that we have introduced to our automation and IT portfolio. So first, let's explore why the labs, they need to automate their processes. We know that the process inside the lab will start by the blood collection and the medical prescription, and it will end up by the results and the discard of the tube as well. But in between, the lab is responsible to do a lot of duties and tasks, from the sample receiving to the lab, specimen analysis, and the needs that we need to do it for the analyzer to get ready for these samples, and also the post-analytical phase with the waste management as well, and the result validation, and as well the confirmation for our results to make sure that all our results are the done on time and right. During this process, it's not easy to manage quality, to reduce errors as well, and also to maximize efficiency, to have a better turnaround time, and also to control cost. We all know that all the service providers, they are asked this day to do more with less. And also these processes need to be lean in order to reach our goals. So what will the automation offer for the lab? The automation for the lab, for sure, it will increase the quality in the lab, and also it will increase the operation efficiency, and as well it will increase the profitability of the lab. And also it will help you to have a better turnaround time, which is the main key KPIs for the lab, and as well it will have a better staff utilization, and for sure it will give you more capability for future growth. And also the automation will streamline the operation inside the lab, which is very important to standardize as well the processes in between all the staff to have the same outcome. And also it will reduce the human error, and as well it's flexible, and it will help you to digitalize the lab. As we know now, everything is going through digitalization. Over the last 20 years, Siemens Healthineers has delivered more than 2,300 total lab automation projects across more than 70 countries. And we had a lot of experience and expertise in consultancy, project management, and other services. So our solution, it's a complete scalable solution that it can meet the needs of all lab sizes, from the small labs to the big labs, and especially to the multi-site network labs. And also our solution will start on the level of the discipline. Also we have solutions for each discipline in the lab, such our Atelica Hema work cell, that it's a real solution for the hematology. And also we have our Atelica solution with the integrated automation. And if we need to scale the way up, and if we need, it's become like crucial to automate all the processes inside the lab, and we can go to our automated portfolio. We have our Atelica task targeted automation, which is newly launched in the market in FY24, and it will help us to automate all the pre-analytical and post-analytical processes. And also we have our strong automation. We have the Aptio automation, and we have the Aptio Flex Lab for the high throughput automation. Now we will talk a little bit about the Atelica TTA, or the Atelica Task Targeted Automation. Does anyone know what can the TTA do inside the lab? So the TTA, or the Atelica Task Targeted Automation, it's covering, it will help you to to automate all the pre-analytical and post-analytical steps, especially if we don't have space to install a total lab automation. Okay, so it will help us to automate up to 12 key tasks that they are available inside the lab. And also, it will help us to do the sorting, because it supports more than 30 different types of rack from different vendors. It's not only for Siemens, it's for the side that they have Siemens and non-Siemens analyzer. Or our solution, they are open and they can accommodate other providers. Also, it has a very friendly graphical user interface, and with a quick changing operating mode. So we can have a mode in the morning, for example, because we know in the morning we have like a lot of samples and it's different processing. So we can have the morning mode, and then we can have, for example, the afternoon mode, that it's mainly sorting or aliquoting or storage for the sample. Also, it has automated task, or one of the key advantage also that it have it, that it can do microplate testing. So it's very important for the lab that they are doing biobanking testing, because it will aliquot in the microplate and will prepare the plate for ELISA testing and also for blood bank testing. And also it's extend and retrofit design. So it's modular. We can add one module, and we can add in future in case the activity and the load has increased inside the lab, or even if we need to automate more processes in the pre and post-analytical phase. I will show you a short video about the TTA and the power of the Atelica task-targeted automation. Can we increase the volume, the sound of? So this is the TTA, and we can see all the pre-analytical steps from centrifugation, decapping, or also aliquoting, that it can be done automatically by the TTA. And also here the microplate dispensing that will help you for ELISA test and blood banking testing. And here is also, once the tests are done, we can archive all the sample in the TTA to be stored in the dedicated refrigerator. Now we will talk about the Aptio automation. Siemens Healthineers has her own philosophy regarding and own concept regarding the total lab automation. As we said, we are available for 20 years in the market, and we have more than 2,300 live automation across 70 countries. So I will start first with a small video that it will show you the power of our Aptio automation.
Aptio automation drives laboratory workflow efficiency based on possibilities, not limitations, to support your diagnostic testing mission. Open connectivity, with easy expansion of high-volume chemistry and immunoassay testing. Unrivaled connectivity, time-tested technology, and an unmatched track record of innovation. Each custom-designed Aptio configuration is designed by experienced workflow consultants using patented tools to accurately project and refine ongoing performance. Integrated and customizable, Atelica Diagnostics IT amplifies TLA performance. Expertly delivered. And supported by award-winning service teams. Total lab automation with Aptio automation is a journey of continual engineering, IT, and service innovations for ongoing improvements in lab performance. Drive one-touch workflow efficiency in open, single, and multidiscipline labs with Aptio automation.
Okay, so as with that, Siemens Healthineers has her own philosophy when it comes to automation and her own concept. So we are offering the end-to-end solution from the primary tube. So the process will start once we receive the tube to the lab till the disposal of the tube. So whenever any tube is loaded in any of our loading module in the automation, it will be routed to the pre-analytical phase, like centrifugation, sample integrity, sample mixing, decapping, and all these processes, they are automated. And we have more than 20 different modules that they can be connected to the track, and they are independently. So we can connect many centrifuge, many decapper. It's not related to the number of input modules that we have it on the track. Once the tube is ready for processing, it will be smartly routed to the dedicated analyzer for processing. And for now, we can connect to our analyzer more than 50, to our automation, sorry, more than 50 analyzers across 11 specialties. And it's open connectivity. It's not only limited for Siemens analyzer, also we can connect non-Siemens analyzer. After processing, the test will be routed for the post-analytical phase. And here we have the aliquoting, recapping, storage, many others, and also the auto-dispose. All this module and analyzer, we can say that they are the muscles of our automation, and they are managed by the brain. Our powerful diagnostic IT portfolio that we will talk about it, that it's covering the whole workflow inside the lab, from the data to the sample management and as well to the material management. Also, Siemens philosophy, it comes to the sample management because we know that all Siemens analyzer, the automation as well, they are working on individual sample management. And in the market, we have other providers that they are working on rack-based sample management. So here just I will show you an example about the differentiation between the individual sample management and the rack-based sample management. We will consider that we have 5 samples in the individual management, and we have 5 samples that they are on a rack. And let's consider analyzer A for immunochemistry and analyzer B for immunoassay. So here we can see how the tube is fast to be released from one analyzer to the second one, and here how it will delay the process because all the samples need to wait for the other test to be aspirated. And here, for example, for analyzer A, it's a chemistry analyzer. So in the majority of the provider, it's not single aspiration. It's multiple aspiration based on the density of the assays. So this for sure will create a delay in sample processing, but the individual sample management, it's fast, efficient sample processing. And here it's just an example for 5 samples. Imagine that you have a bulk of 100, 200 samples, and even if you have dedicated lane for stat sample. So this is very important when it's come to the individual sample management to know how to understand the differentiation between other companies. Also, as you know, that we, our automation is provided by Impico. So we have like a strength partnership with Impico that it will allow us to have the ability to develop or tailor-made any modules that will be a solution for certain customer in the market. So during our journey with Impico since 1998, we have developed a lot of new modules year after year. And from 2017 till the moment, we achieved more than 50 analyzers that they can be connected to the track with more than 700 drivers to connect the analyzer as a standalone to our middleware. Also, our effort always is to solve our customers' problem. So also, we have like a lot of innovation to solve the issues or the problem that they are facing inside the lab. So I'm happy to share with you today the latest modules and innovation that we have introduced to our automation. We have the on-track automated sample volume. So this module will detect the sample volume, and as well it will detect the quality of the sample if it's hemolyzed, icteric, or lipemic before processing. Also, there is one step which is a fully automated small sample or the pediatric sample volume. So this, it's like for a long time a wish list for all the customer to have it. Now it's automated on Siemens platform. So we automated the pediatric tube to be run or covering the pre-analytical, the analytical, and as well the post-analytical on our platform. Also, we are the only company that we are offering the on-track sample mixing. So if you need to run, for example, HbA1c on a high-throughput analyzer, we are offering the on-track mixing that will be responsible to mix the sample before sending these samples to the analyzer to maintain the quality of the sample. As well, we have validated the 3-minute centrifugation tube type that will for sure provide a better turnaround time for the lab. Also, with our diagnostic IT portfolio and our smart system, we are able to have a dedicated routing for the sample on special analyzer, or to give some priority for the samples before other analyzer. As well, our automation will provide the flexibility to dedicate like unloading or sorting module in a different location in the lab. It's not only limited to loading. For example, if I have any discipline that needs samples to be delivered to this area, our automation will be able to do this, because we can use the loading module also as unloading module and for sorting as well. Also, our aliquoter will give us the ability to have a proportional aliquoting capability. So this will help us to only aliquote the necessary volume to be aliquoted in the daughter tube. Okay, so this to preserve the precious sample and to do aliquoting only for the volume that is needed. Here I will show you the list of the analyzers that they can be connected to Siemens analyzer. And this is the largest available list in the market. As you can see, we can connect Siemens and non-Siemens analyzer. We can connect molecular, and the first molecular lab is here in Kuwait. It's as we connected the Panzer to our automation for NAT testing. And we can connect urine analysis, we can collect protein electrophoresis, and as we can see from different from different manufacturer or service provider, it's not limited only to one. And also we can connect HPLC if we need to go for any gold standard methodology, as well ESR, liquid handling, and also we have Siemens portfolio that it's covering the all main pillar of the lab, from allergy, chemistry, immunoassay, hemostasis, hematology, and plasma protein. Now we will talk about digitalization. We know now that everything is going through digitalization. And when it's come to the lab, when we need to digitalize the workflow inside the lab. Okay, so when we talk about the workflow, we need to talk about the data flow, the material flow, and the sample flow. And Siemens Healthineers has software to cover all these processes inside the lab. So first, we have our Atelicad process manager, the APM, that it will be used on the management level, because it's not only to monitor processes, but it will help you to uncover any inefficiency in your process, and it will help you how to solve this, because it will improve workforce productivity with centralized overseeing. And it's not only limited for sample and data, but also for reagent and material that it's available inside the lab. And also, due to the business intelligence and data analytical, it will help you to measure standard and to get up with a lot of KPIs. And also, it will help you to monitor and to get before the turnaround time and the critical value for all samples. And here I would like to share with you some reports that they are built in in the APM. I know that everyone do statistics inside the lab and it will take a lot of time. Here you have built in more than 15 reports that they are real-time report. No need to extract the data for another middleware. It's just only with one click, we can get any reports from turnaround time, reagent efficiency, sample problem, sample hemolyzed, FTE utilization, so everything, and in a real time, so you can plan an action immediately once you get this data, and you can export it as hard copy, soft copy, or even you can take it as Excel if you need to do more statistics with other departments. Also, we have our Atelica data manager that will be responsible to consolidate all the analyzers together. Now we need to consolidate all the analyzers and to have only one screen to monitor everything that is happening inside the lab. So only it will for sure reduce the steps that you will have it, and it will save time, and for sure it will optimize the lab workflow. And once it's standardized in our lab, we can go up and take this expertise to a higher level if we have like other lab connected or other satellite lab, because we can connect everything together with our middleware, even if they are not in the same hospital, if other sister hospital or hub and spoke or PHCs, and then they can be connected to our Atelica Process Manager to have only one screen to manage everything that is happening in our hospital and the other clinics or the hub and spoke. Here we will talk a little bit about the algorithm that we have it in our smart software that will help you to put a lot of rules, from very basic rules to very complex rules, that it will help you on daily basis to monitor your results. So first, we know that the quality control is very crucial to the lab. And any failure with our system, any failure for the QC, it will result by blocking the test for this assay, by blocking this assays and not to release patient data. But for sure, for you, it's very critical. Whenever I have a QC outside the range, I need to know all the patients that I performed within this time. So it's just only one click. I select the QC that it's outside the range and within the range, and I can get the data of all the patients that they has been performed during this time, and I can take the action if I need to repeat any test or if I need to just validate the result. So it's no operator intervention, and here for sure I'm maintaining a quality of for my samples. Also, we know that the QC is very important in the lab, and no one doesn't run QC inside the lab. And running the QC on different platforms, it's not easy at all. And to manage it and to check the QC, to go to one analyzer, another analyzer, and even in the lab, you are using different platforms to manage the QC. So our middleware will offer you the integrated quality control, that it will be integrated into your workflow only from one screen, that you can monitor all the QC that it's in the lab that you performed on your analyzer, even if it's Siemens or non-Siemens analyzer, only from one screen. You can check all the tests that you have it by, for sure, lot number test. And also the integrated quality control will give you a dashboard that it's very easy to do QC comparison, and as well it's color coded. As you can see the exception immediately when it's green, yellow, or red. And also it can hold results after any failure of the QC to make sure about the quality of the results. And what we talk about, the logbacks for the patient if I have any failure in the QC. And also it will help us to do troubleshooting by doing a comparison of multiple QC on the same chart. Okay, so we can do, for example, here the example FT3 with C4, for example. You can compare more than one assays on the same chart to see the performance of this assays at the same time. And also, we have the moving average, that you can use the patient data to calculate the moving average, and it will give you orientation before the failure of the QC. You can see the trend of your patient by using the moving average. Also, the critical results, they are very important for the lab. We know every lab has a different policy regarding the communication of the critical values. So in our system, we can create counters that it will show you whenever you have a critical value inside the lab. You will have a pop-up on the screen showing that you have a panic value. Once I double-click on this screen, it will take me to the panic value that I have it, and then it will give me that this is a panic value. I need to call the doctor because this sample is coming from this department, and I can monitor if the technician did the communication or not. So it's just only one configuration that we will do it in our system, and then it will be easy during our daily operation. Also, the last point is the sample quality. We know that sample quality is very important, and we need to do the test on the best sample quality. So each lab has add-on tests. We know that some sample...
We need to finish, huh?
1 minute, the last slide. So we know that each lab has add-on tests for AR sample, for example. So here the system can calculate by itself the time from collection to the time of the add-ons. If it's more than your criteria, it will reject the order and it will ask for a second tube. So here no need for the technician to check at what time the sample was collected and if it's right to do the test for this tube. So the last slide, I will show you just the Atelica Diagnostic IT portfolio that will have it, how it will simplify the operational workflow inside the lab, and it will it will reduce the complexity in testing that we have it. So we are offering the Atelica Data Manager, we have the Atelica Process Manager, the Atelica Inventory Manager, and for sure, we have our quality management system, the LEAP program that will help you from day 0 to be ready for any type of accreditation. And also we have the sample tracking and management system, the Sample 360, that it's used for the tracking and the transportation of the samples. And also we have the clinical decision support. So here when we talk about a solution, it's not only about automation and analyzer, it's also about the IT and everything that it can come with this solution. Thank you for your time, and I hope that you enjoy this session.
Thank you. So can I call the speakers? Because we have 10 minutes and we have around 11 questions. So the first question, the new technology, more sensitive, more false positive, more test to confirm. What is your opinion?
Is any particular test been chosen in the question? Well, I guess, I don't know. For me, the prototype of the test that leads to confusion due to better analytical performance is troponin. So we went live with high sensitivity troponin in 2016. And of course, a large number of people, we're with troponin T, a large number of people with chronic renal impairment have positive troponins all the time. And there's also a condition where if you have any form of myositis, even statin-induced myositis, you can have ectopic production of troponin T in the skeletal muscle. So, you know, companies always drive for analytical improvements, and these come, you know, with consequences that we face, and I've seen those consequences with troponin. So sometimes I wish that we weren't pursuing analytical performance and we were pursuing clinical performance. So you do need to be cautious when implementing it. Cautious for information that you would have otherwise not known about and you wish you didn't know about when you're bringing in new technologies with greater performance.
Ethically, can lab workers refuse inappropriate tests sent from clinical department?
That's a really good question.
No.
And a difficult one for the laboratory physicians. And I suppose the relationship with the clinician and the laboratory makes it easier. And if you show that, we should never feel that we are inferior to the clinicians. We are also clinicians, and we know what we are talking about. And therefore, if you always interact with the physicians, it becomes easy. As I told you, the first time we introduced the inappropriate testing reduction, the clinicians led it, and we had 20 to 30% reduction. But the next stage, they introduced a manager to work with us. None contributed to this thing, and it's a complete failure, and they lost the money they paid to the manager. So I think it's the relationship with you and the clinicians that will determine whether it's ethically wrong or not. If you show that what you know is right, then they would accept, and they wouldn't argue or have a conflict with us.
So in the same question, in the same scenario, most of clinicians not follow the step-by-step algorithm for diagnosis and always order all available tests in the system. How we can deal with it?
we have this problem everywhere. I don't think we can escape from this, especially the junior doctors, because I hope it works the same way in every country. It's the juniors who manage the flow, and they don't want to be told off by the consultant doctors, and so they will request everything. Because when the consultant comes on ward rounds, they don't want to say, oh, I didn't look at the thyroid. The patient looks hypothyroid. Why didn't you request the hypo? So the clinical skills, as I told you, is also becoming less and less. I don't know if you would agree with that. And every time I tell my children who are doctors, young doctors, the excuse is that we have a lot more to learn than your times. So your clinical skills are better because you had less to learn diagnostics, and therefore they depend on diagnostics a lot. And so that clinical skills is less, and therefore our role as clinical biochemists becomes even more important in education, and educating the doctors, and educating the undergraduates, and educating the postgraduates. We take all opportunities to get to the junior doctors. And I think to get to the consultants is difficult. If you teach the junior doctors, it remains, and they become better consultants.
So I have here also, I have more questions. About accidental discover one case, lead to test many non-needed case, how to solve it, and the new technology of more sensitive, more self-force, most of clinician ethically, who does the coding for the software extracting test statistic used to reduce test over utilization, and how would you initiate this in an institute?
Yeah, so that's a great question, and who does the programming all depends on where you are, but here's how it works where I am. I kind of know what analysis I want to do. And so I am pretty proficient with the R language, and I write the initial analysis in R myself because it's very fast when I'm working back and forth with myself. I investigate something, it doesn't look right, I change the code. Because when you start doing an analysis of lab testing, you'll discover that how you want to analyze it initially doesn't work, and you have to do a lot of back and forth to get something that works. When I want to put code into production, I hand my code to somebody else to make it ready for production, or I ask them to redo the analysis, and then they formally will deploy that software, usually using something called Docker. I'll make reference to that tomorrow. And we will put it either on a server, usually a Linux-based server in lab, or we can host it in cloud. So it is a collaboration between me as sort of a dilettante coder and people who do programming more professionally. Sometimes, however, I have to delegate the whole thing to them, and I just sort of sketch out what I want to see, and I ask them to produce the result, and then I look at it, and it's a lot slower that way. But it's a mixture of people who are dedicated programmers and people who are sort of amateur programmers like me.
And I have so many questions, but this is going to be the last question because of the time. How can we make a time interval for repeating tests and other effects, for example, drugs?
The time interval.
For the time interval.
And I think, again, the electronic patient record, it could have alerts or blocking if the time is not right. The patient identification will have the time the sample is taken. We don't process the sample until they put when the medication was given so that we can calculate the time. So we could improve the electronic patient requesting by putting in the details what we want so that inappropriate requesting for drugs can be reduced.
Yeah, we created a test. This was a big problem. It's all for all therapeutic drug monitoring that we had this problem. That if you don't, I'm not sure if the question was referring to time of last administered dose or the interval with which you will cancel a test, but I'll answer both questions. For the last dose question, we made a last dose test code for all therapeutic drug monitoring. That does create some problems in overdose settings because the clinician can't fill that spot, so you have to make it optional to fill it because there are times when people have taken an overdose of valproate and they don't care when the dose was administered. With respect to the interval around blocking or giving pop-ups around testing, there was that database that was from, from Australia? Yeah. The Australian Society of Clinical Pathologists, Clinical Chemists have tackled this problem. And also you can look statistically at prior ordering practices, and then you can apply clinical skills. So we applied clinical skills for most tests that would be a problem. You know, sodium, you might order that every 30 minutes in someone with DKA, but you wouldn't order it more than every 30 minutes or every half an hour, or every 45 minutes or something like that. So we went through each test code one by one, applying both statistics and clinical skills to that.
So please applause for our speakers for the first session.
Thank you very much.
And they're going to be available for any questions, so you can mingle. Before we conclude session one, I would like to remind everyone that we have a competition at the end of the day. There will be available prizes. I have no idea. Dr. Salwa knows about it. To be won, with the 3 winners to be selected based on questions from today's lectures. Thank you all for your attention and active engagement. Thank you.